everyone. In this episode of I Forgot to Ask the Doctor, I interview Professor Emma Crosbie, consultant gynaecologic oncologist. We discuss endometrial or womb cancer, the symptoms, red flags, investigations, and treatment options. Please have a listen. Hi everyone, thank you for listening to my podcast. In this episode, I'm going to interview Professor Emma Crosbie about endometrial or womb cancer. Emma was an easy choice to invite onto the podcast as she is the most cheerful person that I know. She is also a brilliant doctor. Emma is a professor of gynecological oncology in Manchester. She is widely published and is internationally recognized for her work on endometrial cancer and Lynch syndrome. She heads up a very prolific team of researchers who are affectionately known as Team Womb. I consider myself very lucky to have Emma as a colleague and a friend. Emma, welcome. Thank you for taking the time out of your very busy schedule to be interviewed today.
Thank you very much, and thank you for that very glowing introduction. That's too kind.
Well deserved. So Emma, it always intrigues me to know why colleagues choose certain specialties or subspecialties. So can you talk a little bit about what interested you in cancer, and in particular endometrial cancer? What drew you in to work on that?
So I think I always wanted to be a cancer doctor because I could see that there was so much work to be done in terms of improving outcomes for patients. So there's so much to learn about how we could diagnose cancer at an early stage, if there were things that we could do to prevent it, and also working out better ways for treating cancer. So there just seemed to be so much to be done that it seemed a really exciting area to want to study. And I've always wanted to be a clinical academic, and that's what I do just now. So I spend half my week doing cancer research and half my week looking after patients with gynecological cancer. And this is just the best job in the world because it means that you get inspiration from your patients about the kinds of research that you think will make a difference for their outcomes. So it was kind of a no-brainer that because I was interested in cancer research in an academic way, that I would then be wanting to look after patients with cancer. And so really, I'm very, very lucky to have this fantastic job that allows me to combine both interests.
Well, what a wonderful answer.
Thank you.
So as you know, the main purpose of this podcast is to reach and educate patients. So we are going to try not to use any medical terms if we can avoid it. And if we do, we'll explain them. Is that okay?
Sounds good.
Okay. So let's start at the beginning. What exactly is endometrial cancer? Where does it start? Where does it live? Can you just describe it for us?
So endometrial cancer is cancer of the lining of the womb. So we call endometrial cancer womb cancer or even uterine cancer. There's no kind of agreed terminology that is used everywhere. So here in the UK, we use the term endometrial cancer, and we're specifically referring to a cancer that develops within the lining of the womb. And this is the endometrium. It's a really important organ. It's the organ that grows every month in premenopausal women in response to ovarian hormones and then is shed in a period. So it's a very active organ. And also it's the area within the womb that nourishes the conceptors, so a new pregnancy, that's where it embeds and implants and starts to grow. So it's really, really important for women's health and for reproduction. And we know that in lots of different places they use different terms like uterine cancer. And in general, most uterine cancers are endometrial cancers, but you can also get cancers of the muscle layer of the womb, which are slightly different. So we're talking today about endometrial cancer developing within the endometrium.
Thank you. Thanks for clarifying. So most women will have had a smear test and they'll be familiar maybe with the concept of abnormalities of the cells of the neck of the womb, which is again different, isn't it?
Yes, it is.
And some women may know that you can have mildly, moderately or severely abnormal cells of the neck of the womb. Is there a similarity with the cells of the lining of the womb, or is it completely different? So are there kind of pre-cancerous stages?
So yeah, there absolutely are. So there are different types of endometrial cancers, but the most common type is called an endometrioid endometrial cancer. And this type often develops in a background endometrium that's got precancerous cells. And we call that, when it's inside the endometrium, we call that hyperplasia. So in other words, the cells are growing too fast or too much. And then when you look at them under the microscope, they're very crowded. The cells are pushed together, and it looks more crowded than in a normal endometrium where they are separated by something called stroma. So these medical terms we don't need to understand, but essentially you do get a precancerous abnormality within the endometrium called hyperplasia, and then a cancer might develop in there. The more rare cancers of the endometrium that don't develop in a hyperplasia are ones that often develop in a polyp, in a malignant polyp within the sort of endometrium, more likely in a postmenopausal woman who's a bit older. So there are different types of endometrial cancers, and some of them have got more recognised precancerous stages than others.
So the fact that they're precancerous stages, does that give us an opportunity to treat or influence the abnormality before it becomes cancer?
Absolutely.
And is that do we frequently capitalize on that opportunity, or is it kind of in retrospect, if we had done this before, we could have prevented the cancer? Or is that a significant part of current management, that if these cells are picked up, and we'll talk about how they're picked up later on, can they be influenced, can they be treated in order to prevent the progression to cancer?
Yeah, so we do and we don't capitalise on this opportunity as much as we can. So there are some women who unfortunately develop these precancerous changes when they have not yet completed their families. So when they're in their 30s and early 40s, and they would really like to have more children or start a family. And in those women, we can try to treat the precancerous cells of the endometrium, the hyperplasia, using hormone treatments. If women have gone through the menopause and or have completed their family, no longer wish to use their uterus for babies, for pregnancy, then the kind of safest treatment, if the woman is well enough to have surgery, is a hysterectomy. So removing the womb, and typically the neck of the womb, the fallopian tubes and ovaries at the same time. So we tend to reserve treatment of precancerous abnormalities for premenopausal women. Yeah. And, you know, in that scenario, there isn't a huge amount of different treatments that are available, but the one that we do know about is hormone treatment. And that can be delivered either directly to the endometrium in a little coil called a Mirena. So that is a little device that sits inside the endometrial cavity, and it releases the hormone in progesterone in a continuous way over weeks and months or even years. And that hormone, the progesterone hormone, helps to make the lining of the womb thin again and to get rid of the hyperplasia.
Okay. And is that the same Mirena coil that many women will use for contraception, for example, that's readily available?
Exactly the same. So
it's not a special one for cancer, it's the same Mirena coil.
Same one. So it can be used for contraception, it can be used for people with heavy periods, it can be used for HRT, if people have estrogen tablets or patches, and it can be used to treat these precancerous abnormalities of the endometrium. If the Mirena isn't something that the woman wants to have, or if it doesn't stay in, so for some people, you know, the endometrium doesn't retain the Mirena as well as for other people. For example, if there are fibroids inside the uterus, then tablets can be given. So they can have progesterone tablets, and they basically do the same job, but they are given by mouth and can cause more side effects because they go in the blood to do their work. Whereas with the Mirena, it just needs to work within the endometrial cavity. So it produces hormone and works locally, and it tends to have less absorption into the circulation and causes less side effects.
So a much lower dose is needed, sort of thing, generally speaking.
That's right.
Yeah. Okay, perfect. And just to clarify, I'm going to touch on this one more time. Because I certainly see many patients who, for example, we'll talk about the symptoms. So, for example, they may come with whatever symptoms, say abnormal bleeding, or they may not come because they say, Well, I've had a normal smear test, so I wasn't worried about it. Does the normal smear test rule out abnormalities of the lining of the womb, the endometrium, or cancer of the lining of the womb? Can you just clarify the difference?
Yes, it absolutely does not. So a smear test is used for cervical screening. And in the UK...
And the cervix is the neck of the womb.
It's the neck of the womb. And in the UK, we take a sample of the cells from the neck of the womb, from the cervix, and we then test them for high-risk HPV, which is the virus that we know causes abnormalities of the cervix. So it causes cervical precancer and cervical cancer. And that's a completely different thing from abnormalities of the endometrium. Now, actually, it's an interesting question because you can actually sometimes detect abnormalities of the endometrium and endometrial cancer with a normal smear test. So in the past, we used to look at the cells down the microscope. That was the first test that we did when we did a cervical smear test. And sometimes you could see abnormalities of the endometrium by looking at the cells that you find on that cervical scrape. But nowadays, because we only look down the microscope for those that are HPV positive, then we miss that opportunity to find abnormalities of the endometrium on a standard smear test. But actually, there's quite a lot of interest in using that kind of sample for developing new screening tools for endometrial cancer, because if you can find the cells and look at them under the microscope, then there might be other ways that you could pick up an endometrial cancer from the cells that you collect from the neck of the womb. And there's a lot of interest in doing all kinds of genetic testing, looking at the proteins that might be in that sample to see whether there's a signal that there is a cancer inside the uterine cavity, inside the endometrium. And there's a huge amount of interest in this because at the moment, really the only way to pick up an endometrial cancer is using a whole load of tests that I'm sure we'll talk about in a short while. Those tests are obviously expensive, they're anxiety provoking, they can be uncomfortable for some women. So if we could find something that was much less invasive, that could be easily done, in the community setting, then that could be of great interest to us.
That'd be amazing. That would be absolutely amazing, wouldn't it? Yeah. Okay. So just to put an absolute end to it. At the moment, a normal smear test with the smear test that we use now routinely does not rule out abnormal cells of the lining. You need separate tests for that, which we'll get into.
Correct.
Is that fair to say?
Correct.
Okay. But of course, we can encourage women to go along for the smear test, obviously, because that's equally important. Yeah.
Yes.
So moving right along to symptoms. So I said, some women may have symptoms and they say, I've had a normal smear test and therefore I didn't worry about it. What are the symptoms that should concern patients and prompt them to seek medical attention? Okay, so the endometrial cancer.
Endometrial cancer. So what we call the red flag symptom of endometrial cancer is abnormal vaginal bleeding. And because most endometrial cancers occur in women who've gone through the menopause, so they're called postmenopausal women. So that's usually women older than 51 or 52 years of age, because that's the population of people that tend to get endometrial cancer, then the red flag symptom for endometrial cancer is postmenopausal bleeding. So any bleeding after the menopause should prompt a woman to go and see her GP to say, I've had some bleeding. Some women aren't aware of when they went through the menopause, or it might be difficult to know that they've gone through the menopause. And usually we define having gone through the menopause in retrospect. So we say, well, if you've stopped having periods for a year or more and it's not due to pregnancy or hormone treatments or anything like that, then you're considered to have gone through the menopause. So it's a year after your periods stop, you would then be considered postmenopausal. And of course, a lot of women will experience menopausal symptoms like hot flushes, night sweats, so on and so forth, which will be another indication that they've gone through the menopause, and they will not be having any bleeding. So if they then suddenly develop bleeding, any bleeding, whether that be spotting, streaking of the underwear when wiping, or more recognizable like a bleed, they absolutely need to go and see their GP about that. If they have not gone through the menopause, so they're premenopausal women, perhaps in their 30s or 40s, then endometrial cancer is much less common. But nevertheless, it does happen. And because it's quite challenging to work out what is causing abnormal bleeding in women who are still having periods, I would say that anything that's different for you is an indication that you should see somebody just to make sure that all is well. So, different people have different experiences of bleeding. But if that changes, so if that becomes that you suddenly have very heavy periods that don't seem to stop, or you have spotting or bleeding between periods, so things that are different for you would be a reason to go and see your GP and say, I've had abnormal bleeding for me. And there's this whole thing about recognizing your normal and when it becomes abnormal for you.
Yep, absolutely. So called a change in menstrual habit. You're having periods for so many years. Suddenly, something's changed. Do seek medical attention for further investigation into that. And again, I just want to highlight the point that many women say or may think that, well, actually, it was only just a tiny bit of bleeding. I hear that a lot. It was only a tiny bit of bleeding, so I ignored it. But you've just said, any bleeding, any postmenopausal bleeding, correct? Women should seek advice. So I just wanted to highlight that point, whether it's a tiny amount of spotting, whether it's flooding, both are abnormal and both need to be investigated.
That's absolutely right. And there doesn't seem to be a correlation between the amount of bleeding and the likelihood that there's a cancer there. So we unfortunately see plenty of people who've just noticed a spot or two of blood. And then we do the investigations and we find out they do have endometrial cancer. Yeah. Other patients where they noticed quite a lot of bleeding, like maybe even like a period that they used to have. And when we do all the tests, there's nothing there. So there isn't a correlation between the amount of bleeding and the chance of finding a cancer. And so we say any abnormal bleeding, particularly after the menopause, you should get it checked out.
Perfect. Great. Or a change in menstrual habit.
Or a change in menstrual habit. Yeah. Yes. So I'm talking more about postmenopausal bleeding because that is the reality for around 80% of our endometrial cancers. They are in older women. Yep. But a change in menstrual habit for those who have not yet gone through the menopause is also really important to get checked out. And usually that is nothing for us to worry about. It's because there are, they're taking hormones or they're having a stressful time or for whatever reason, perhaps there's an infection, something like that. Bleeding before the menopause is usually due to something else. But nevertheless, it should be checked out because unless we can say it definitely isn't cancer, it would always be something that we would worry was the case.
And I guess bleeding in younger women may be, it may not be cancer, but it may be hyperplasia that you can then treat.
That's right.
If left alone may become cancer later on with time. Is that correct as well?
Or it might be a polyp, or it might be an infection, or it might be something else that needs treatment. So it's always worth getting abnormal bleeding checked out. So a change in menstrual function, exactly as you say, you should go and see your GP.
Perfect. And just to clarify for our listeners, so a polyp is like a skin tag of the lining of the womb is how I usually describe it. Whereas a fibroid was another thing you mentioned is the womb is made of muscle, the wall of the womb, and it's when the muscle organizes itself into a ball of muscle. So it's two different things. And polyps are the one that are more likely. But they're both very, very common. Absolutely.
And they are nothing to worry about.
And they're generally speaking nothing to worry about. That's it. Perfect. Okay. So by virtue of what you said, about 80% of women with endometrial cancers that you see are postmenopausal. That leads me nicely onto my next question, which is, are there any risk factors for endometrial cancer? So I'm guessing that age is a pretty prominent risk factor. Is that correct? And are there any others that you could mention?
So age is the main one. So the chance of this abnormal bleeding being due to endometrial cancer goes up the older the woman is. So if she's in her 70s or 80s, that it's much more likely to be an endometrial cancer that's causing that bleeding than if she's in her early 50s. So age is really, really important. The other things that are important are being overweight. So excess body weight is a really strong risk factor for endometrial cancer. And then there are other reproductive risk factors, such as never having had children, having started periods at a very young age, or having finished periods, so going through the menopause at a relatively late age. So these are reproductive risk factors, if you like. There are metabolic risk factors, so people who suffer from polycystic ovary syndrome, or people who have type 2 diabetes, they have a metabolic syndrome, and this is another risk factor for endometrial cancer. And then there are genetic risk factors, so endometrial cancer runs in families, so if you have a first-degree relative that's had endometrial cancer, then you are at increased risk. And then there are also inherited cancer predisposition syndromes, such as Lynch syndrome, which increases the risk of endometrial cancer.
Okay, thank you. And we'll get onto that in a little bit more detail later on. So therefore, following through from what you're saying, a woman say a premenopausal woman who's had a bit of a change in menstrual habit, if she has any of the other risk factors, it's an even stronger reason to go along pretty quickly to be investigated. Everybody should, but it's really good to be aware of risk factors. And the second thing to say is that you've listed several risk factors, and one of the really important things of knowing about risk factors is okay, maybe I'm a slightly higher risk of this thing, whatever it is, I better go along and get checked. Or B, maybe some of those risk factors I can influence to decrease my risk of contracting whatever condition we're talking about. And in terms of endometrial cancer, so for example, does weight loss influence contracting it, or a hyperplasia becoming cancer, or treatment?
Yeah, you're absolutely right. So the risk factors tend to be sort of negatively correlated with the protective factors. So while being overweight or obese is a risk factor for endometrial cancer, being lean or normal weight is a protective factor. And if you are overweight or obese and you lose weight, you reduce your risk of endometrial cancer. So that is something you very much can do for yourself to reduce your risk of endometrial cancer and a whole host of other different cancers that are caused or associated with being overweight or obese, and other health conditions, heart disease, sleep problems, joint problems, So there are lots of reasons why, if you're overweight or obese, it's a good idea to try to lose weight. Being physically active, so regular physical activity or exercise, even if that's just walking, brisk walking 3 times a week for 30 minutes or more, that protects against endometrial cancer. In terms of the reproductive risk factors, that's all to do with having relatively too much of the female hormone estrogen. And so in the same way that we treat hyperplasia with the hormone progesterone, increasing our exposure to progesterone can also help protect against endometrial cancer. And by that, I mean taking things like the combined oral contraceptive pill or hormonal contraceptives that contain progesterone. We know that young women who take these contraceptives are at reduced risk of endometrial cancer in later life. So I'm not necessarily advocating that we all start to take these hormonal treatments, but it is interesting to know that if you're taking them for contraception or for bleeding or other gynecological problems, that they have a positive side effect, which is that they reduce your risk of endometrial cancer.
Yes, because some women worry that it's the opposite, that taking the hormones will increase their risk. But what you're saying is the exact opposite to that. So that's good news.
Right. Yeah. So those are the main ways. Obviously, if you have had a hysterectomy, around 1 in 5 women will have a hysterectomy during their life, and usually for benign reasons like fibroids or heavy periods or ovarian cysts. Clearly, if you have a hysterectomy, then that is ultimately the best way of reducing your risk of endometrial cancer. But again, that isn't something that we would advocate for this reason, unless you're in a very, very high risk category, such as having Lynch syndrome, in which case we do recommend risk reducing hysterectomy to reduce the risk of endometrial cancer once a woman has completed her childbearing and she's in her 40s or later.
Okay, thank you very much. Okay, so we know what the risk factors are. We know what to look out for when women should seek medical attention. So when women do go along to their doctor to seek medical attention, what should they expect? So what I'm asking is, what are the investigations that are performed in order to investigate whether endometrial cancer is present or not?
So because the main symptom is abnormal bleeding, when a woman goes to her GP with abnormal bleeding, then the GP will ask a lot of questions about that. And some of the questions that they will ask are you up to date with your routine cervical screening? And they might want to have a little look at the cervix to check that it doesn't look abnormal.
Yeah.
And if they've excluded an abnormal looking cervix and the woman is up to date with cervical screening, then the next thing that needs to be excluded is endometrial cancer. And so there are recommendations that GPs should refer patients with abnormal bleeding after the menopause for urgent investigation to rule out endometrial cancer. And that's on a what we call a 2-week wait urgent basis. So the idea is that if they see their doctor in the community, that they should then be referred to a gynaecologist in a hospital, a district general or a teaching hospital, and that should happen within 2 weeks. So they should be seen after they've presented their GP within this 2-week golden window. And when they come to the hospital to be investigated, then generally there's a whole load of different tests that are used in a sequential way to help to reassure us that there isn't endometrial cancer or any other cause for the bleeding that needs us to take action. And usually the first test that women will have is an ultrasound scan. And that's usually done with an internal probe, so an ultrasound probe that goes into the vagina. It's called a transvaginal ultrasound scan. And the reason why we do the scan that way is that it gets a much better look at the endometrium than a scan that goes through the tummy. And sometimes it's quite difficult to see the lining of the womb through the tummy. And so we know that this transvaginal ultrasound scan is much better at allowing the ultrasonographer to have a look at the lining of the womb and check how thick it is. So that's usually the thing that they want to know first of all, is how thick is the endometrium. And the reason for that is that we know that a very thin endometrium is not likely to have an endometrial cancer. But the thicker and thicker that it becomes, the more likely it is that there's an abnormality, whether it be hyperplasia or whether it be a cancer. And if there are irregularities, like something that looks like it could be a polyp, then again, that's an important piece of information because it helps to decide what happens next. So in this country, we usually a cutoff of 4 millimeters for postmenopausal women. So women who have gone through the menopause, the endometrium shouldn't be any thicker than 4 millimeters. And if it is, then that takes the woman through to the next sort of layer of tests, if you like. In a premenopausal woman, it's much more difficult to define a cutoff for what looks abnormal. And that's because there is a normal cyclical fluctuation in the thickness of the endometrium. And that's because she's having periods. So it gets thicker and then it's shed and it gets thinner again. So there's no cutoff in the way that there is for a postmenopausal woman on how thick it should be. But they would still do a scan because you can see if there are polyps or thickenings or cystic spaces, that things that look suspicious for hyperplasia. It's not just how thick, it's also the character of the endometrium. So in a premenopausal woman where it looks abnormal, and or in a postmenopausal woman where it's thicker than it should be, then woman would then be sent to a clinic where they would have other tests. If the endometrium was very thin, then they would not need any more tests at that stage.
Yeah.
So the next set of tests are hysteroscopy and endometrial biopsy. Sometimes we just try an endometrial biopsy without doing a hysteroscopy. And that's when we think that the lining of the womb is kind of thick but regular. And we try to take a sample of the lining of the womb with an outpatient aspiration device, usually something called a Pipelle endometrial biopsy. But if there are abnormalities that make the endometrium irregular, so if we think there's a polyp there or a focal area that looks abnormal, we might be worried that taking the outpatient sample of the endometrium using the Pipelle could miss that abnormality. And so we combine taking a sample of the endometrium with a hysteroscopy. And the hysteroscopy is a thin a thin scope that goes in through the neck of the womb, through the cervix and into the uterine cavity to visualize the endometrium and look for abnormalities. There's a camera attached to the scope, and essentially it allows the person that's doing the hysteroscopy to find any areas that look suspicious. If it's all looking normal, then they might not need to have a sample taken. But in general, if there's an abnormality there or if the lining was thick, then they would combine the hysteroscopy with taking a small sample of the endometrium, either with the hysteroscope or afterwards using the aspiration device, the Propel that we talked about before. And so it's this combination of knowing that the endometrial cavity looked normal and the cells were normal under the microscope that is very reassuring that there isn't an endometrial cancer there. But of course, if an abnormality is detected and a sample is taken, then that increases the risk that there is an abnormality. And it all boils down to extremely skilled doctors called pathologists who recognises the changes in the cells down the microscope and are able to say, do you know what, I'm worried that this is a cancer. So that would then be the definitive test, if you like, for endometrial cancer, is that pathology sample.
Okay, great. That's a fantastic description. And just to say that hysteroscopy can either be performed as an outpatient or under general anaesthetic. And I certainly give all my patients a choice of which.
That's really important.
That's really important.
So most people tolerate procedure in the outpatient setting without any issues. Some women are understandably nervous about it and reluctant to have it done in the outpatient setting. Others can't tolerate it, find it uncomfortable. Some find it painful.
Some find it very severely painful. Some
find it severely painful.
Absolutely.
So we always explain that before we do the hysteroscopy, and we always offer women a choice of analgesia and anaesthesia.
Correct.
If a woman at that stage says, I don't want to have it done whilst I'm awake, then we respect that. And we do the procedure whilst she's asleep under a short general anaesthetic. If she would like us to try to do the procedure with her awake, and she then finds that she's not finding it something she can tolerate, it's uncomfortable, she wants to stop, we always stop. So we are here to help get a diagnosis, but we are not here to make women feel uncomfortable.
Absolutely.
We are doctors that are trying to do the best thing for our patients. And if a patient isn't happy with having it done in the outpatient setting, there's no problem asking to have it done under general anaesthetic.
Yeah, or even it's offered beforehand. Both options are offered in the first instance.
That's right.
Okay. So we've spoken about risk factors, we've spoken about symptoms, we've spoken about investigations. So next along the line is, what are the treatment options? And I suppose they may be myriad, and you will know this in great detail. But if you can give us an idea of what the treatment options are, perhaps for maybe for hyperplasia, you've mentioned that before, the Mirena coil or the hormones, progestrogens that you can take via tablets, or hysterectomy, of course. What are the treatments for endometrial cancer and of different stages?
So the standard treatment for endometrial cancer is a hysterectomy, and we usually remove the womb, the neck of the womb or the cervix, the fallopian tubes and the ovaries. And that is the standard procedure that we do for most women with endometrial cancer. And in general, it's curative if they have early stage disease. So if we've picked up their endometrial cancer at an early stage, then we are generally lucky enough that hysterectomy is all that the patient needs. If they have risk factors that mean that the endometrial cancer is a more aggressive type of cancer, or it has started to spread into the muscle of the uterus, to spread deeply into the muscle of the uterus, or to involve lymph nodes, or to spread elsewhere outside the uterus, then these are patients who would need additional treatment. So there are the majority are low-grade, early-stage endometrial cancers that are cured by hysterectomy, but those with risk factors may need additional treatment, and that might be radiotherapy and or chemotherapy after their surgery. And then there are a group of women who have got advanced disease or very aggressive disease at initial treatment. And in those patients, then chemotherapy, radiotherapy and surgery might be needed. Sometimes it's not possible to offer a hysterectomy because the womb cancer is so advanced, and they may start with chemotherapy, and if they respond well to that, there may be an option for surgery. So it does depend very much on the stage. It also depends on the age of the patient and what their wishes are for fertility. So there are around 10 to 15% of women who have endometrial cancer when they haven't gone through the menopause, and some of them may not yet have had their families or may not have completed their families and would like to have the option to retain their uterus for future pregnancy. In reality, that's a small proportion of the patients that we deal with, because actually endometrial cancer is more common as you get older. So it's quite uncommon in early 30s, late 20s, late 30s, which is when most women would want to have their children. That isn't to say it doesn't happen. Of course it does, but they are, less common patients for us. But if they have early stage, low grade endometrial cancer and they wish to keep their uterus for future pregnancy, then we can sometimes manage those patients with the Mirena coil or with the progesterone tablets. So sometimes that's successful. It does mean that the patients need to have quite a long duration of treatment with the hormones. And that means they need to be very closely monitored during that treatment to make sure that things are getting better and certainly not getting any worse. So that can involve a lot of coming back and forth to the clinic for biopsies and scans to check that all is well. But we have had successful treatment with hormones, whereby women have then be able to go on and have babies, sometimes more than one, and that's all because these hormone treatments do work for low-grade early-stage cancers in some cases. It depends. There's a whole lot of things that I've said there, but it depends on the individual woman. So we individualize treatment. We listen to what women want. We look at the whole picture in terms of how well they are, how advanced the disease is, how fit they are for surgery, and we kind of take it from there. So we always discuss our patients in a group team meeting, which is called a multidisciplinary team meeting, where we have all the experts sitting together, the gynecologists, the pathologists, the radiologists, the doctors that give the chemotherapy and the radiotherapy, and we all sit and discuss together what the treatment options are, and then we offer them to the patient, and we, on the whole, try to honour their wishes if that's feasible and safe.
Perfect, great. So again, this comes back to, if you have abnormal bleeding, the sooner, because you said that in most cases of endometrial cancer, they're curative by hysterectomy.
That's right.
Because I guess they're diagnosed relatively early.
Yes.
As opposed to some other cancers that can present later, show up later, because the symptoms and signs aren't that, specific.
Exactly. Yes.
The abnormal bleeding really hammers home. If you have abnormal bleeding, please go to be investigated, because it means, it shows itself potentially at an early stage where relatively simple surgery can be curative. Do you agree with that statement?
Yeah, I totally agree with that. It like you say, it shows itself. The bleeding is the red flag symptom that we need to listen to our bodies.
Don't ignore it.
The abnormal bleeding is something that we need to see our GP about. Absolutely. The earlier we can get the cancer diagnosed, the more options there are for treatment, and the less morbid those treatments are. So the less impact they will have on the patient in terms of long-term side effects, and the chances of the cancer coming back. these are increased as we become more advanced and the treatments are less effective, and the treatments are more radical. So the earlier the better. So any abnormal bleeding, do see a GP.
Perfect. Okay, great. And can you speak a bit about HRT? So once treatment has been completed, and as you said, it will often involve hysterectomy and removal of both ovaries, even in premenopausal women, or most cases are in women who are already postmenopausal. So many women may be interested to know what are the rules as regards HRT in women who have had endometrial, who have survived endometrial cancer, who have been successfully treated by someone like yourself. What are the rules? Can they have HRT, or is it off the table?
So the first thing to say is that we are now gaining more and more experience in leaving ovaries in for those premenopausal women with early stage low grade endometrial cancer. And actually the studies that have been done, they aren't randomized controlled trials because it wouldn't be ethical to randomize a group of patients to have ovaries out or left in. So that hasn't been done. But the data that we do have, and quite large studies, quite large prospective studies from lots of different countries around the world, would suggest that it is safe to leave ovaries in for low-grade early-stage endometrial cancer, and indeed that their survival outcomes might be better, because we know that taking ovaries out in very young women is actually not good for them. The ovaries are producing estrogen, which of course stimulates the endometrium. That's why we take them out. But they do a really important job in keeping our bones healthy, our heart healthy, and keeping at bay the kinds of symptoms that women experience when they go through the menopause. So some women will be able to have a hysterectomy and their fallopian tubes removed, but their ovaries left inside. And that will be the premenopausal women. Women who are sort of in their late 40s, or women who have got more advanced disease than that, even if they're premenopausal, then the advice would be that the ovaries would need to come out. And that is because they're producing estrogen, which theoretically could stimulate the endometrial cancer and increase the risk of it coming back. So advanced stage endometrial cancer, we almost always take out ovaries. For postmenopausal women, we take them out because we think that there isn't an awful lot of use to keeping them at that stage. And, women who have their ovaries removed, do sometimes then suffer from menopausal symptoms. That's more common if they have it done at a slightly younger age than if they have it done in their 60s and 70s, for example. And again, it would depend a lot on what the endometrial cancer was like. So if it was low-grade early stage cancer and they were having what we would call debilitating menopausal symptoms, then HRT could be safe. If the symptoms that they're getting are urogenital, that is, they are getting things like vaginal dryness, difficulty with repeated urine infections, prolapse symptoms, then they may benefit from estrogen given into the vagina in a cream or a pessary. And actually, there is no contraindication to giving that at all. So even with women with this more aggressive, more advanced endometrial cancer, they can have vaginal estrogen after they've had cancer, because the systemic absorption, so that is the absorption of the estrogen delivered into the vagina, into the circulation, is so low that it just isn't going to cause any problems with recurrence. So it's a theoretical risk of the cancer coming back with the estrogen in HRT. But the reality is that we don't have good evidence that it will. But most oncologists would err on the side of caution if a patient has a more advanced or more aggressive endometrial cancer.
Brilliant, fantastic. And finally, from me, can you explain to us what Lynch syndrome is? You've mentioned it a few times, and we know that you are massive in the world of Lynch syndrome. You've done lots of research about it, and you're really, really passionate about it. Can you explain to us briefly what it comprises?
So Lynch syndrome is an inherited cancer predisposition syndrome that's thought to affect around 1 in 300 of the general population, but only 5% are aware of their diagnosis. Lynch syndrome is caused by an inherited pathogenic variant affecting one of the 4 mismatch repair genes, and these are called MLH1, MSH2, MSH6 and PMS2. And these 4 mismatch repair genes together are responsible for making sure that when DNA replicates, it does so accurately. So if you have Lynch syndrome, then you're at increased risk of cancers of the bowel, so colorectal cancer, of the endometrium, endometrial cancer, ovarian cancer, and several other cancers. And these cancers can occur at a young age, and an individual might have more than one cancer diagnosis during their lifetime. And so because we know of this link between endometrial cancer and Lynch syndrome, that can serve as a really important opportunity to try and diagnose Lynch syndrome. Because if we find out that a person has got Lynch syndrome, then that empowers them to engage in risk-reducing interventions to reduce their risk of future cancers. So things like having bowel surveillance, so colonoscopies, which can pick up precancerous abnormalities of the bowel and early stage cancers. These are things that people with Lynch syndrome can do to reduce their risk of future cancers. There's other things like taking aspirin. We know that aspirin reduces the risk of cancer in Lynch syndrome. And also, if a person has Lynch syndrome, then their family members may also have Lynch syndrome because Lynch syndrome is inherited in an autosomal dominant way, which means that a parent passes it on to approximately half of their children, whether they be girls or boys. So around half of their first degree relatives may have Lynch syndrome too. And if they are healthy carriers of Lynch syndrome, then there is an opportunity again to engage in interventions that can reduce their risk of future cancers. So knowing about Lynch syndrome through testing endometrial cancers is a really important opportunity to try and help people prevent cancer in the future.
And they're all cancers tested for Lynch syndrome?
So they are now. So work that we did here in Manchester actually showed that it is clinically effective, cost effective, and patients want to be tested for Lynch syndrome. So we now routinely screen all endometrial cancers for Lynch syndrome. There's a test that we do on the tumour that looks for these mismatch repair genes, the proteins of those genes. And if they are there, then the person doesn't have Lynch syndrome. But if they are missing, then that person may have Lynch syndrome. And then there are other tests that are carried out to finally potentially diagnose or exclude Lynch syndrome as the cause of that person's endometrial cancer. So that now routinely happens for everyone with endometrial cancer and everyone with colorectal cancer. So we are screening everybody, and that's because we believe very strongly that knowledge is power, and knowing that you have Lynch syndrome empowers you to do something about your future cancer risk.
That's wonderful work, Emma.
Thank you.
It really is. Okay, so thank you for all those amazingly thorough and clear explanations, which is exactly what I expected from you. And as you know, I asked listeners beforehand if there's anything that they would like me to ask on their behalf. Would it be okay if I asked you a few questions from our viewers who have sent them in?
Of course.
Okay. So I must say you're really popular, so there are a few. I can't ask every question that was submitted, but I'll do my best to ask quite a few. So I must stress at this point that it's very difficult to give specific and personal advice to patients without a thorough knowledge of their past and current medical history, examination findings, etc. Also, due to time constraints, I've summarized some of the questions in a way that I think retain the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor or gynaecologist. So, our first question is from a 40-year-old patient who had a hysterectomy due to Lynch syndrome. Her ovaries were retained, so the ovaries were left in. She has a background of having lost, unfortunately, a brother to Lynch-related colon cancer. Her question is there any benefit in her taking the contraceptive pill in relation to lowering her risk of breast or ovarian cancer?
Okay, so that's a really great question. So it just assumes, my answer assumes that she has had her hysterectomy to reduce her risk of endometrial cancer rather than because she had endometrial cancer herself. So assuming it was a risk-reducing hysterectomy
to prevent endometrial
cancers, well. In the future, then it's a great question as to whether or not the combined oral contraceptive pill could help reduce her risk of ovarian cancer. And of course, we know that the combined oral contraceptive pill does reduce the risk of ovarian cancer. We're not 100% certain that it does so in Lynch syndrome, because until now we haven't been picking up Lynch syndrome as much as we should. But we do know in general that the combined oral contraceptive pill reduces ovarian cancer risk, and it is a very reasonable way that a person may try to reduce their future risk of ovarian cancer. The issue is that once you get to around 40, the pros and cons, the risks and benefits change, and most general practitioners do not prescribe the combined oral contraceptive pill to older women because they are at risk of some of the more serious side effects of taking the pill, like stroke, for example, blood clots, and so on. So it really does depend on how fit and well the person is that's asking the question. But certainly we know that taking the pill is helpful, and it may be something that she can discuss with her doctor. In terms of breast cancer, we don't think the pill helps with breast cancer. In fact, we think there might be some evidence that it slightly increases the risk of breast cancer, depending on the preparation used. It might simply bring forward the diagnosis. In other words, a cancer that was always going to happen happens at a slightly younger age. But certainly we don't think that the pill reduces breast cancer risk. And if anything, it may slightly increase breast cancer risk, although the jury is still out there.
Okay, brilliant. Complicated answer. Complicated question, yeah. Okay, so our second question is from a listener who says she has severe endometriosis, which was diagnosed at around age 14, so in teenagehood. She has a family history of endometrial cancer, and her grandmother was diagnosed 6 years ago and has recently had a recurrence of endometrial cancer. She says she knows she's at increased risk, but every time she ever goes to see a doctor or ends up in A&E due to pain, it's put down to the endometriosis, which she says is probably the case. She says there have been no recent changes to be concerned about, but she's always worried about the future. What if she has changes suggestive of endometrial cancer? How can she get professionals to understand that it's different and that it's not the endometriosis that's causing her symptoms, so that any possible endometrial cancer is taken seriously?
Okay, so that's again a complicated question. But what I would say is that endometriosis and endometrial cancer cause different symptoms, and the predominant symptom for endometriosis is pain. As she says, she's been to the hospital several times with pain that's been so severe that she's needed pain management, whereas endometrial cancer tends to present with abnormal bleeding. So I would still think that, if you went to see your GP with abnormal bleeding, that should be taken seriously, because that's unlikely to be due to the endometriosis if the typical symptoms that she has is pain. So I think still go to the doctor and trust that they will take you seriously if you've got abnormal bleeding, because they will.
Yeah, perfect. Our third question is, what are the latest statistics for stage 3 and 4 serous carcinoma? Are the survival chances getting better?
So that is one of the more aggressive types of endometrial cancer, unfortunately. So we know that when somebody is diagnosed with a serous endometrial cancer, then it tends to have a much poorer outlook than the types of cancers that I was talking about before, the endometrioid endometrial cancers. So unfortunately, the outlook is poorer. We are now moving away slightly from deciding on treatments based on the character of the cells down the microscope. So whether they be serous or endometrioid, and instead moving towards a time when we do molecular classification of endometrial tumours. So we look at the molecules within the tumour and we divide the patients into groups based on how their tumours look molecularly, if you like. So not looking at histology solely, but instead looking at the different genetic changes and protein changes that the tumour shows. And using this better way of characterising endometrial cancers, we can work out in a much more refined way exactly what treatments to offer our patients. So we are personalising treatment in a much better way based on the molecular characterisation of endometrial tumours. And whilst these serous tumours tend to be the ones with poor outlook, knowing what their molecular profile is can help to adjust exactly what type of outlook they have and therefore what treatment they should be offered. So we're getting so much better at targeting chemotherapy towards an individual tumour. So looking at that molecular profile and knowing what drugs to hit it with, if you like. So it's about understanding the molecular profile of the tumour and targeting treatment to that individual tumour, and doing that enable us to get the best possible outcomes. But absolutely, unfortunately, these type of cancers are the more aggressive ones. Yes.
Okay. So for a fourth question, this lady has had a total hysterectomy and bilateral salpingo-oophorectomy. So her womb has been removed, the neck of the womb, both tubes and both ovaries, several weeks ago. And this was for complex atypical endometrial hyperplasia. So not cancer, but the complex hyperplasia for our listeners. Histology, however, showed early stage invasion into the muscle wall of the womb, the myometrium. She was told that she can probably continue with HRT, as she does have debilitating symptoms, as you mentioned before. Her question is this: is there any data regarding the risk of recurrence with HRT in early stage endometrial cancer? And you've answered that already, I think.
Yes, I think so. So, sorry, carry on.
And should she have estrogen only or combined HRT?
Okay, so yes, there are some data that suggest that with early stage, low grade endometrial cancers, that HRT is safe. And certainly we would give it in the case of debilitating symptoms. So usually we try our patients without HRT, but if they are really suffering, then we would recommend a low dose HRT, but only in those with early stage, low grade endometrial cancers. In general, because she's had the full hysterectomy and her uterus removed, this means that she doesn't need combined HRT. She only needs the estrogen. So combined HRT is both estrogen and progesterone. The progesterone is put in there to protect the endometrium from becoming abnormal. But if it's been removed, then all she needs is the estrogen. And actually that simplifies things quite a lot, because she could then just have a patch or a low dose pill that she would take every day and not worry about having to have, progesterone given, either by mouth or a Mirena, for example. So it makes it a lot simpler, but it does depend on the grade and the stage. And I think in this particular case, with debilitating symptoms, I would prescribe estrogen-only HRT.
Brilliant, perfect. Okay, last question from our listeners. Do you see a cure for endometrial cancer in the future in the USA or UK or anywhere?
So that's really interesting. That would be fantastic, wouldn't it?
Yeah.
I think probably the best thing that we can hope for at the moment is prevention and early detection. Curing it would require us to really look at the molecular profile and, it's not one disease. That's the thing. Although it's affecting one organ, the endometrium, it's lots of different cancers in there that are all caused by slightly different things or might respond to slightly different treatments. So it's not a one cure fits all kind of thing, unfortunately. But I do think that there may be opportunities for prevention, as we talked about before, maintaining a healthy body weight, being physically active, perhaps using hormonal contraceptives, Mirena coil, for example. These things can help to prevent endometrial cancer or risk-reducing hysterectomy in Lynch syndrome. And early detection, we talked a little bit about how there are new non-invasive screening tools that are looking for endometrial cancer biomarkers that can help us to identify women at risk of endometrial cancer. So I think these are our two main areas of hope at the moment, because cure is a little bit more complicated. But I still have hope.
There's a lot to hope for. Okay. So finally, Emma, you have seen and managed many, many women with endometrial cancer. You have seen firsthand and been involved directly in their patient journey. If you had the opportunity to say a couple of things to patients who have or may have this condition, what would you tell them?
I think with regards to who may have this condition, it's, as we've been going on about this whole podcast, is to seek advice early if you have abnormal bleeding. Know you're normal, get abnormal checked out. And for the others who are perhaps just diagnosed and going through a very anxiety-provoking time, very concerned about what treatment they will need and what their long-term outcome will be, I think my advice would be that, we want to look after you. We want to do the best that we can for you. And we will use the current evidence to make sure that you're getting diagnosed and managed in the best possible way. So, try not to be too anxious. And we will work with you to try and get this treatment in place as soon as possible. And there's lots of hope for the future.
And there's lots of support as well for these patients.
Yeah, absolutely. We work with this fantastic team where we have clinical nurse specialists who specialise in supporting our patients through this cancer journey. And there are loads, it's a very anxiety-provoking time. Families find it very stressful. It is a very challenging time, but we're here to support you. We're here to give you all the treatment options that you would like to talk about. And really, that's what we're here for. So don't be afraid to ask questions, and we will do everything we can to get you through it.
Perfect. So before I close, Emma, I really want to say a massive thank you for your time today. I know how busy you are, and for sharing some of your vast knowledge with us. I think it's going to be so valuable to patients. I've really been looking forward to this. As you know, I've really been looking forward to this and excited about it. And it's just been fantastic. Thank you for supporting my podcast, for being a wonderful colleague, and most of all, for working so hard for patients with endometrial cancer and Lynch syndrome. Thanks so much.
Thank you, Gail. It's been a pleasure.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.